Mary Ann, will you read call roll, please?
Shelley.
Here.
Susan Birchfield.
Here.
Wayne Dennis. Not. He's absent. Courtney Edwards.
Here.
Linda Galvan. Absent. Deborah Nichols.
Here.
Jennifer Northway. Not here. Ram Perez. Kara Tapley.
Here.
And Stuart Williams. Hi, Stuart.
Okay. Thank you. Prior to this meeting, we sent copies of the February minutes to the committee members. I don't know if you have copies of them or not, but I'll entertain a motion to approve the minutes from the February meeting.
So move.
Thank you, Susan. Do I hear a second?
Second.
Courtney? Any discussion? All in favor say aye.
Aye.
All opposed, same sign. Motion carries. Okay, now it's time for the Courtney Edwards show. Courtney, you want to give us an update on the Trauma Systems Committee Registry Work Group?
There is going to be a face-to-face meeting tomorrow with the members of the committee. There's been several conference calls working through some of the issues, discussing some of the collaboratives with partnerships with like RACD and how they're working with it, looking from an EMS side, the hospital side. Yesterday, after the TTCF meeting, the state did a demonstration for those that use web entry to help them work through some of the processes. There's been lots of improved communication regarding the validation reports and the errors and how to work through those processes from the hospital standpoint. The LTACs and rehab facilities started entering data in March for TBIs and spinal cord injuries. So that's also moving in that direction.
Okay, thank you. TTAF update?
For the TTAF update, yesterday they met and there was discussion on the collaboration with TTAF and AT&T. AT&T has accepted the partnership, working on a statewide injury prevention initiative regarding distracted driving. So the final details are still being worked out between TTAF and AT&T, but there is some information up on TTAF's homepage with the anticipated big rollout in August.
Okay.
So that's moving in that direction, so that's good. And then, of course, all the legislative updates and with the legislative session going on, being very acutely aware of what's happening with that in the driver responsibility program.
Okay.
And then regarding the TTCF update, they met yesterday as well and had some discussions about things. The education that they had was there was a panel discussion regarding some of the lessons learned from the West explosion and some of what is still being hashed out in that. And then also there was a presentation by law enforcement on active shooters in the hospital settings and gathering information that you could move forward from that and taking care of that process.
Okay, thank you. Stuart, it looks like you're ready to go with your presentation, so we're going to skip around on the agenda. Next up is our committee member, Stuart Williams, is going to do a presentation on policy and system change for mapping injury data, community collaboration, and action planning. And this is a presentation that was accepted at the National Injury Meeting that will be held in Baltimore early June. So this is about a project that Dale Children's Medical Center Injury Program did here in Austin. And so Stuart, you're on.
Thank you, Shelley. Yeah, so this is a pretty long title, so I'll try to get right to it. This is a project that we were involved in the last several years. It's a project that is still ongoing, and I'll kind of give you some of the updates as we go through it, but I want to give you some of the basics to start with. Dell Children's, if you're not familiar with our facility, this is our facility. It's right down the road, about a mile. And this is some of the basic information about our facility. Receiving 85% of the pediatric trauma patients in Central Texas, 74,000 of ED visits a year. In our trauma services alone, we see about 1,500 patients each year, and my staff directly is involved in the care of those patients as well. So our program as a whole, just to kind of give you a little bit of background where this project originates from and how it came to be, we use a socioeconomic model in our program, the injury prevention program, which is very, very similar to what a lot of different public health entities use, all the different areas around the individual, all the different layers. And so we try to develop our programming or our interventions with that model in mind. Another approach to it is some work by Larry Cohen in the spectrum of prevention. You've seen the spectrum of prevention presented here with what the work of the injury committee is doing around the different risk areas, but really trying to take that spectrum of prevention and implement it towards an actual community project. One of the things that when we took a self-assessment of our program, we found that we were very, very comfortable in these bottom levels. Now, how the spectrum prevention works is basically the lower levels are the least influential parts of the spectrum. The higher up you go, the more influence you have on the population, basically. And so this is where we find ourselves quite often, is in the education, the community education, strengthening individual knowledge, that very individual approach. And it takes a tremendous amount of resources to do those. It can be somewhat easy to check the box and move forward with, but we wanted to really move to the higher levels and try to influence developing coalitions and networks, changing organizational practice, and influencing policy and legislation. When I say policy and legislation, I'm not necessarily saying legislation across the state, but more of policies within organizations, policy within our local community groups or within our local governments, not necessarily those high ticket items of policy legislation at the state level. So that's where we tried to focus most of our attention with this project. Leaves us with a big question, and that question is, how do we get there? We know where we're at. We know where we're located. We know where our patients are located. We know where crashes are located. So it really comes to center around this one big pinpoint, and that is the location, location, location. This is not actual data. This is just an image just to get the effect across. We have a tremendous amount of trauma registry data at Dell Children's. And so this project looked at addressing where our injuries are occurring basically over 3 different areas: motor vehicle crashes, pedestrian crashes, and bicycle crashes. It doesn't matter if you use a map with push pins. That's a basic way to identify clustering, a really basic way. Community programs can do this. You don't need really intricate software to do. You can use Google. Google has an application that allows you to pinpoint where things are as well, and you can start to see where your injuries are. My computer is locking up a little bit here. We use ArcGIS with Children's Optimal Health, and I'll get into that a little bit as far as what our connection with Children's Optimal Health is. But this is an example of some of the maps that we were able to develop through this project. And I'll get into them a little bit more. So our project partners basically were Dell Children's Research Department, the injury program, obviously, Children's Optimal Health, which is a mapping utility that we utilize for our community. They're involved in multiple different projects, but they were instrumental in this project in helping us to develop these maps. The Austin Police Department was an integral partner in this, providing us with APD crash data. And then we utilize also the UT School of Social Work, which I won't really get into talking about here so much, but that was a part of the project where they actually went out in the identified areas and did observations. So our basic analysis was a retrospective review over from 2007 to 2009. So that dates this project quite a bit, but we're still utilizing the information that we have here because it's one of the most current bits of local information that we have to really identify targeted areas. And so we're trying to stay on top of those individual targeted areas. And really, the action that comes from this is specific to those targeted areas. Roughly around 200 some injury cases that we pulled from our trauma registry data from Austin Police Department, about 8,000 collisions with children were looked at. And that's all broken down in the actual individual maps. Again, using Children's Optimal Health to map the school social work in the hotspot areas. So this particular map, and I apologize for it being a little bit difficult to see, is roughly 8,924 collisions involving children from APD's data. And you can see the majority. I'm just going to run through these maps real quickly because it's the additional information that I want to share with you. But it shows mostly that I-35 corridor is where we're seeing a lot of our motor vehicle collisions involving children. We also plotted it by zip code, but you can see when you just use zip codes, it's very difficult to really narrow it down to what are the actual individual areas that need addressing. This was daytime motor vehicle collisions involving children. 7,000 cases here, just over 7,000 cases, same time period, but only between, the crash actually occurred between 6 a.m. and 9 p.m. Very heavy. When you look at pediatric involvement, though, it changes at night, and this is the night from 9 p.m. to 6 a.m. We also looked at the locations that resulted in fatality or very serious injury. And these hotspots, this is really where a lot of our focus has been addressed. One of these hotspots, the top one, is actually right outside our doors here at the 290 Runberg area. Then we have a hotspot in the Ben White area, and then down in the bottom one is actually Dove Springs. And this particular map, it's limited. It only represents 83 collisions that resulted in fatality or serious injury. From the trauma data, we looked at residents of where those children that were injured in motor vehicle collisions actually live. And they're not too far from where the actual crashes appeared. So a lot of our interventions have actually, one of the things that we found from this is a lot of the interventions that we were involved in were not necessarily in the targeted areas that we needed to be in. Since this report, or since this study was completed, we've had the opportunity to actually reallocate a lot of our resources and some of our intervention work into these actual neighborhoods. Just to show the importance of mapping your information, if you are able to collect your information so that you can be more strategic with your actual interventions. This is the residence of those that were on or under restrained. That's all spelled out as far as what the definition of those, how those definitions were developed in the actual full report. This was the residence of those that received citations from APD for un or under restrained child occupants. This was the collision between child pedestrians, cyclists, and motor vehicles. And it's difficult to see on this map, but actually the yellow and red, it's very, very small because the numbers are small, but they're in the very same areas, those same intersections and road areas that appeared in the motor vehicle crashes. The Runberg, Ben White, and Dove Springs areas. The hotspot areas were then ranked basically from 1 to 12. The top 12 clusters were ranked, and this represents about 309 collisions of pedestrians or cyclists. These are pediatric pedestrians or cyclists with a motor vehicle. The residents of those pediatric cyclists or pedestrians as well. So what came of this project? The action, we wanted to take this data and move it one step further. Just reporting on it doesn't really do all that much. So we actually drew together a bunch of our partners with Children's Optimal Health, Dell Children's somewhat leading that charge. We developed an injury summit that was very pediatric focused around these 3 areas. We brought together several of our partners, and we had a half-day summit that really kind of tried to get into the depths of these maps. That summit obtained quite a bit of news coverage here in the Austin area, which also generated quite a bit of interest by City Council. This was just an example of the information that went out from for the summit. The results, though, was that the City Council passed a resolution, and I'll show you a copy of that resolution here in a second, that basically led the way to develop a relationship with our community partners. It may not be necessary you can make coalitions, you can develop partnerships without a policy being passed, but this is an example of a very small policy that actually gave us some teeth to sit down at the table with Austin, with the different departments in Austin City, Public Works, Transportation, Health, and then also bring additional partners to the table and make a larger coalition to address some of these areas. This is the resolution. Basically, developing a comprehensive plan is what this committee, this organization, this coalition was developed to do. Develop a comprehensive plan. We call it a strategy, and then communicate how we're going to go about this. And then, obviously, City Council was holding us accountable in wanting a report back in 90 days. So this is what the Transportation Safety Committee looks like. The Childhood Transportation Safety Committee looks like in Austin. We basically developed somewhat of a framework. The logos below are just some of the organizations that are involved, just to give you a sense of how that's made up. We broke our work out into 5 different areas: community education intervention, public policy, engineering in the built environment, in the enforcement work group, and then data collection, sharing, and use. 3 focus areas, obviously, that all of these work groups were working to, or are working to develop their individual component of the strategy that we're trying to put together in relation to each of these 3 focus areas, in relation to the actual hotspots that were identified in the previous project. Some of the actions items that have happened as a result of this coalition coming together: we have started to work on that 3-year safety strategy for pediatric transportation issues. We are currently in the process of obtaining new data to update 6 of the maps in the original report to see some comparison between what was done back at the original project, to see if all the interventions that have occurred or the work that we've discovered from our partners is actually making a difference in some of those hotspot areas. And we expect those maps to probably within the next 2 months. Opportunities to strengthen city ordinances. A lot of the discussion in some of the work groups have identified some of the gaps or some of the barriers that need to be overcome. And so there's some strategy and some action that's being planned around some of those things. How do we take this a step further and actually strengthen some of our city ordinances? And then probably one of the biggest components, at least from our programmatic standpoint, is just having very strategic allocation of our materials into our for our community programs into those areas that we know need help. The committee basically developed 5 goals that you can see here that basically span over all of those different work groups: building the infrastructure, increasing the capacity, evidence-based methods and interventions, strengthening advocacy and influencing policy, increasing the existing education and training venues that are out there, not only just for the individuals in our community, but for the professionals that are out there trying to do this work. and identifying the gaps in collection, not only just in the collection, but the review and sharing of information. One of the things that we identified through this project, or through the action component of it, was that some of our departments, or some of the interdepartments within departments, do not necessarily have the connections. And when you bring them to the table, all of a sudden these connections start to work, and you can see across the table someone has this epiphany: oh, I need to be in contact with you. Why haven't we worked together before? And so this is why it's so important to bring these these different partners together. This is an example of some of the very infant work. Another policy being, another resolution being passed by City Council. This one is pretty specific to a task that came out of the enforcement work group, really trying to focus on how do we increase the capacity of our child passenger safety techs in Travis County. Currently, we have about, at least from the CPS, the Safe Kids CPS website, 32 technicians that are currently registered within Travis County. Now, that doesn't necessarily mean that that's the only number of technicians that are in Travis County if the individual is registered, say, at their home residence and it's in a different county. But as far as when you do a search on Travis County, as far as CPS techs, you're coming up with about 32. So there is a need, and we know that across the board, despite what the numbers are, that the number of individuals that are riding at risk in our vehicles is a lot higher than the number of child passenger safety technicians that we have to actually address that issue. And we know that that's a evidence-based intervention that we can do. And so one of our projects, or one of the components of this plan, was to get City Council on board. They wanted us to look for funding for a specific initiative to help secure a child passenger safety course within Austin on an annual basis. That's the idea behind this resolution. In addition to just our summit, the Transportation Department in the city also held their own summit. And many of you probably were a part of that. It was a lot larger summit. It was not necessarily pediatric specific, but it encompassed all age groups, and it encompassed all different types of transportation modes: light rail, bus, walking, motor vehicle. And it was held very much in the same similar format that our original summit was held. And there was over 58 organizations. I don't know the exact number, but there were at least over 58 organizations based on the list of organizations that they had in their initial invite that actually attended. So what has it done for us programmatically? This is just an example of us as we move forward with our programming at Dell Children's, and knowing the power behind mapping our information, mapping the data that we are able to collect. When we go into the community to, say, do a booster seat distribution event, we are collecting information on where our resources are going. That helps us to come back and see, are we actually addressing, to make us accountable, to see if we're actually addressing the areas that we know are most in need. And so as of today, in this last fiscal year, now this is not counting about 175 booster seats that weren't put into this map yet, but this is 475 booster seats that went into our community just this past year. The purple shaded areas are the residential areas, basically, where those booster seats landed. And you can see it's starting to fall along that I-35 corridor, which is exactly where we wanted them to be. This is one of my favorite quotes, and it really came from a presentation that I saw Larry Cohen present in Dallas, and I really think that this sums it all up. We spend so much time and so many resources trying to address the educational component and changing individual behavior, but if the society around us is supporting that behavior, we can throw everything we want at it and it's not going to change. We have to start looking at some of the higher levels of the spectrum of prevention in order for those changes to actually occur. So with that, I thank you.
Thanks, Stuart. Do any committee members have any questions for Stuart? Any audience members have any questions about the project or? Okay, yeah, Marianne.
Stuart, what program did you say that you had to do the mapping? What was the name of it again?
ArcGIS.
Okay.
9.3.1.
Okay. That's what well, okay.
It's
Okay.
been updated since then.
Thanks, Stuart.
You're welcome. Thank you.
Next on the agenda is the Injury Prevention Committee for several months now has been working on, and Stuart alluded to this in his presentation, a spectrum of prevention over different injury categories. Those are, I believe, available now on the GTAC website. We have, like I said, we've been working on them for several months now, revising them. What we've tried to do is put in evidence-based information in each of the 6 categories or each of the 6 levels of the spectrum. We have one on motor vehicle crashes, just motor vehicle crashes in general, teen driving, alcohol-related motor vehicle crashes, older adult falls, pedestrian safety, drowning safety, residential fire safety, intimate partner violence, child abuse, and concussions, and I believe that's all of it. At our last work group meeting that we held in Temple in April, the group pretty much what we felt like finalized the information, made a few minor tweaks and changes, but because we didn't have a quorum at that meeting, we decided to wait until this meeting to vote on those. So I will, at this time, entertain a motion from the committee to accept the spectrum of prevention on the different topics as final. Do I hear a motion?
I make a motion that we vote to approve
Thanks, Marianne.
the prevention papers.
Thanks, and Kara seconds. Any discussion on the spectrums? Okay, all in favor of finalizing the spectrum of preventions, say aye.
Aye.
All opposed? Okay, thank you. I will remove I think right now, what I sent to Dishes, it had a draft watermark on those, so I will send those out next week as final. Those will be available on the Dishes website under the Injury Prevention Committee. And again, these were developed as tools and references and resources for people who either, whether you're at a hospital-based injury prevention program, a county health department-based injury prevention program, so that you can look at them and say, hey, we're going to do something on pedestrian injury. What can we do? And you can pull those up and see what's recommended as evidence-based. Next thing is at the workday meeting, we had some discussion about the need for this committee to develop some position papers, and there was a lot of discussion, and it was basically, I think the committee as a group, or those that were present, decided that position papers are nice, but let's not just develop one just for the sake of having a position paper. Let's not create more work for ourselves. There was, I think what we finally decided was that I would take a shot at developing one on the need to train the workforce and things like that, which I think I probably promised I'd have by this meeting, and it didn't get done. So that will certainly go on our next workday meeting agenda. But I think what we'd be interested in hearing is if there is a position paper that you all, as the stakeholders, feel that this committee could do, and we'll entertain suggestions on that. And so, no? Is that a no? Okay. Well, we'll certainly take another look at maybe developing one on workforce development prior to the next regular scheduled meeting. I'm going to skip around now too until we can wait to get the computer ready to discuss the GTAC Committee Council meeting schedule. But at our workday meeting, we also discussed the possibility of having future training opportunities, future injury and violence prevention conferences. TTAF started offering courses back 2009, 2000, yeah, I think so. In 2010, we had a statewide. This committee was. Along with DITCHES, helped us plan a statewide injury conference. TTAF went back and did another symposium in 2011. Then in 2012, we had another statewide conference, and then this year, TTAF had another symposium. So we had some discussion at our workday meeting about do we want to plan another statewide conference? There was a lot of discussion about just as budgets are tight and times are tough, it makes it hard for people to get to. Not only it makes it difficult to get to a conference, but it also for the statewide injury meetings, Dale Children's has really stepped up to the plate and put a lot of finances behind the 2010 conference and the 2012 conference. And personally, I hate for Dell to continue to do that. I think at one point we thought that there might be that we would get enough traction that it could be a self-funding and self-sustaining meeting, but I don't think we've reached that point. And I think those on the GTAC committee have felt like that. You know, it's taken about 18 months to plan both of them. So we sort of tabled the idea of doing a statewide injury conference in 2014. In 2014, there will be a an international world injury conference in Atlanta, Georgia, that will be sponsored by the CDC in October of 2014. So at this point, we've decided that we're probably not going to plan a 2014 Texas statewide conference, but we also talked about the possibility of piggybacking on some type of a training opportunity if one of the trauma centers are having their trauma conference. If there was a way to do like a track for injury and violence prevention that might not be clinically related, but would be more for the practitioners who are out in the community doing injury and violence prevention. So I know that JPS has one annually. We'd be interested in if you all are planning trauma conferences, if you would get in touch with us, if you're interested in having an injury and violence prevention track. What we talked about is that we feel like that as a committee, we have some not only some contacts statewide, but we also have contacts on a regional and a national basis that we might be willing to, for example, I might at the Injury Prevention Center of Greater Dallas might be willing to pay somebody's travel fees to come in to speak at the conference. So we might be able to pool some resources that way, and we just felt like that was probably a better use of time and resources at this point, is just trying to piggyback with potential trauma conference, statewide trauma conferences that are going on. Does anybody from the committee have anything to add, or did I miss anything on that?
I would just say that we have received numerous inquiries into whether or not we are holding another conference in the future. I think there is a large interest in it. I think that our injury prevention, violence and injury prevention, individuals in our communities do need the resources that are provided in that forum. So if we can at all possible tag along and make a separate track for injury and violence prevention at one of those trauma conferences, it would be well received, I think.
I might add that I have heard that Arkansas which is a relatively easy flight from Austin, Dallas, Fort Worth, other places within the state of Texas. But Arkansas, who is part of this CDC's designated regional network where Texas also resides in the South by Southwest Regional Injury Network. But anyway, sometime in 2014, Arkansas is planning a conference and has invited us to it will not just be an Arkansas statewide conference. They're looking for people within the region to attend. So when we have more information about that, we'll certainly publicize it and promote it through GTAC meetings. Does anybody have any comments, questions about injury and violence training conferences? Okay. Are we ready to talk about the, those of you who've sat in on all the meetings today know that this has been a topic of discussion at every meeting, and poor Jane, you probably should have just recorded yourself saying this. But the GTAC Council back in February started talking about future GTAC schedules, and it's at the time it was we were looking at, or GTAC was looking at confirming meeting space for 2014. So there were a lot of discussions about changing the schedule. What you're going to see here, what Dishes has put together, is there are 5 different options, and our task for the committee today is to decide on in rank order those different options. Now, what you're going to see are 5 different options, but what is not up there is the option of keeping it the schedule as it is right now, which involves 3 days of GTAC meetings with GTAC starting on Wednesday and ending by noon on Friday. So I know that I think the Pediatric Committee did this too, but I also know that the Education Committee put the current schedule in as the 6th option. But all of the 5 schedules that you're going to see displayed on the next few slides begin with a 1-hour GTAC meeting that actually starts the GTAC meetings. All of them allow for all 10 of the committees to continue to meet. All of the meetings begin day 2 at 8 a.m. Versus later in the day. They all end with a 2-hour GTAC meeting. So Jane, if you'll pull those up so we can see what the different options are. So we're going to go on. What you're going to see on the slides are the 5 different options. Committee members, I'd like for you all to be looking at the different options and then decide, we as a committee will decide how we want to rank them and present them to the GTAC Council on Friday. And Jane, do you want me to go through them? Do you want to go through them, or?
We can do it either way, Shelley. I can start.
Okay.
Option A, these are all numbered, they're all alpha numbers. GTAC schedule option A, we start at day 1 with at 1 o'clock the council would meet for an hour. During this council meeting, we would get a lot of the department reports that we currently do now in the beginning of the GTAC meeting would be given. That way, a lot of the repetitiveness would be done up front, and the committees would all hear that. The committee chairs would be there, and they could hear that and pass that on to their committees. On day 1, after the 1-hour GTAC meeting, we have 4 1-hour committee meetings, and we would finish at 6 p.m. Then on day 2, we would start again with committee meetings, and these are all 1-hour meetings. We start again on day 2 at 8 a.m., and we have 6 committee meetings on day 2. We conclude with a 2-hour GTAC meeting, and that again concludes at, let's see, that's 4 p.m. So, and again, those are all 1-hour meetings. Now, you'll notice that on day 1, we start at 1. There's no lunch break. On day 2, there's also no lunch break. You don't have a break in the committee, so it would be a working meeting. Whichever committee is going to meet from 11 to 12 or 12 to 1, those committee members may be eating lunch at the table while they have their meetings. Okay, so that's option A. Next one. Option B, day 1. Again, we start, all of these options will start with a GTAC meeting, a 1-hour meeting. So we have an hour on day 1 for GTAC. Then you have 4 consecutive committee meetings, and these are running for 50 minutes. So there's a 10-minute turnover between meetings. Okay. Day 2, you have 6 meetings starting at 8 a.m. And again, it's a 50-minute meeting. There is no lunch break. And then GTAC starts at 4 and goes to at 1400, which would be 2 o'clock, and concludes at 4 p.m. Okay. It's option B. Okay, go to C. For option C, day 1, we're starting earlier than the other 2. We're starting at 10 a.m., runs from 10 to 11, would be the first hour of GTAC. Then you have hour-and-a-half committee meetings following that. You have 4, beginning at 11 o'clock. You do have an hour's break in between the first and second committee for lunch, and we would conclude at 6 p.m. Day 2 begins at 8 a.m., and you would have 6 committee meetings. These are all hour-and-a-half meetings. Yes. And we do have a break for lunch on day 2 for an hour. And then GTAC would convene at 6 p.m. and end at 8 p.m. Okay. Next is option D. Day 1, again, we begin at 9, from 9 to 10 with a GTAC meeting. And then thereafter, we would have committee meetings. There would be 5 on day 1. And you can see that they vary from 1 hour to an hour and a half on those committee meetings. We would conclude at 5:30 on day 1. Day 2, we begin again with committee meetings at 8 a.m. And these are all hour-and-a-half meetings. And GTAC concludes at 6:30. And then the final option is E. Day 1 is an early start, 8:30 to 9:30 GTAC. 5 committee meetings. Runs, let's see. We have an hour and a half. We have a mixture of an hour and a half and hour meetings. We do have a lunch break for an hour. The committees conclude at 5 p.m. Day 2, start up again at 8. And it runs for each committee meeting in the morning, runs for an hour and a half. The afternoon committee meetings, beginning at 1 o'clock, are running for an hour. So there are 2 committee meetings that run for an hour. And then GTAC is 2 hours from 3 to 5. And this is a summary of those days.
Thank you, Jane. Committee members, do you have any questions?
So, Jane, if a committee needs an hour, that particular session, do they meet for an hour, and then maybe the next time they need an hour and a half? Is that just going to rotate? How is that going to work? Is that going to be assigned each committee? Will our committee only have an hour forever, or will we be able to flux in and out depending on the schedule?
I don't think that's really been defined, and I think that's still some conversations to be had. Some of the conversations were that at the initial 1-hour GTAC meeting, that we might look at which committees would get the 1-hour session and which would get an hour and a half. Could be defined prior to that based on the committee's chair's feedback to the chair of GTAC when we're setting committee agendas up. So that would occur probably 30 days out. So there's a variety of different ways that it could work. keeping in mind we'd have to be mindful of the open meetings requirements and to be sure that we didn't violate that.
Any other committee members have questions for Jane? Well, why don't we just, I think what I'm going to do is start, and keep in mind, option 6 is to keep it as it currently is. One of the things that I heard in earlier meetings today were that some people, if they have to travel long distances, they're going to have to come in the night before anyway, and so it doesn't really make any difference if it's 2 days versus 3 days. And I remember, I do have a question for you, Jane. I'm trying to remember, was there a cost? Is it cheaper, I guess, for dishes to have it 2 days versus 3 days? And was there a significant cost difference? And
there's not a significant cost difference for us. We just have to contract. We contract with the hotels about a year out. So we were trying to decide back in February what we were going to do for the actually fiscal year 14. So that was kind of the discussion. I think the cost, the discussion with the council has been some of those council members coming in and them traveling in and then staying here for 3 days and traveling back. That's where some of the discussion on the cost has come in.
And then just to clarify, is this for 2014 or are we talking about 2015? Because haven't you already signed the contract for next year's meetings?
I think that's right.
Is it, is Kelly?
I think we've already signed contracts for 14.
Okay.
So it would be
14 will remain the same. Mm-hmm. So what we're looking at here would start in 2015.
Right. Well,
okay.
What they wanted to do is whatever the committees come up with in their rank order is to do a test run for August potentially.
Gotcha.
That was the
okay.
discussion in February.
Gotcha. Okay.
I have a question,
Courtney?
Jane. Are they looking to target Wednesday, Thursday being the 2 days, or Thursday, Friday, with possibly not getting out till 8 o'clock on a Friday? Do you know what days they're targeting?
I think most of the feedback that we heard was that people preferred Wednesday, Thursday versus Thursday, Friday for that very reason. But again, I don't think that's actually been determined, but that was what I remember was the general consensus was that Wednesday and Thursday, if we're going to 2 days, those were the 2 days that were preferred by the majority of the people that spoke. And y'all correct me if I'm wrong out there.
Okay. And I'm going to borrow something that Jody said during the education meeting. So committee members, I'm going to be here regardless. So this is up to you all to decide. I will do whatever. So what we need to do is rank them, and I will present this to the council on Friday. So does anyone like option number A as our first choice?
I do, actually. A is my favorite.
Okay.
What's the asterisk on option B?
I think that is, I'm trying to remember, is that no lunch? I don't think that neither one of them have lunches. I don't remember. Oh, that's right. I'm sorry. That's right, Stuart. It's 50 minutes. So it's, and actually I heard somebody in the pediatric committee say, it's going to take 10 minutes to change, from one committee meeting to the next. So, option A may not be, even though it looks like an hour, you probably, but it is. Those are 50-minute meetings.
And I think it was, excuse me, I think it was brought up earlier, I think it was by Scott back there, that on the days that start at 1300, it might be an option for the divisions to meet that morning. For example, when we met at TTAF, for TTAF, the divisional meetings, do those meetings in the morning. which could be an option.
You know, before I ask committee members to vote, are there any comments from the audience and the stakeholders? Come on in. And would you tell us who you are, please?
My name is Eddie Walker. I'm with Life EMS Academy and Life Ambulance in El Paso. And I can't speak for all of the folks from El Paso, but those that I've talked to, regardless of what option we go to, or even if we stuck to the same one, those of us from the extreme western side of the state are still going to be here for 3 days, even if we went to a 1,300 hour meeting. A concern that we have is the cost. We flew in Tuesday night, pay full fare for the hotel, and if we have to incur that cost to fly in the day after or a day before, and if we have to stay that extra night, that may be extra cost that we are incurring. So I just ask that be taken into consideration in any kind of contracts that might be taken up or anything. But like I say, from El Paso, we're here for 3 days anyway. My preference on it would be option E, because that evenly balances the 1 hour meetings and the 1.5. And if committees will rotate through those hours, that's just an hour meeting for the committee every other month.
Okay. Thank you.
Jane, do we have any information on, like, I know trauma systems typically goes the full hour and a half. Do we have times on, like, the other committees that, you know, we know that this committee typically runs around an hour and this one runs around an hour and a half? And would they meet that equal distribution?
No, we do not keep those statistics. But I will say that the addition of this little clock over there has made everybody ahead of schedule today.
It's like a ticking time bomb staring at you.
Right. You know, and Courtney, I think that's a very good question. I've been on the Injury Prevention Committee now for 4 years, and I think we may have gone, in my memory, may have gone the full hour and a half, maybe once. Even before I was the chair, we ended earlier. So, and I know the meetings this morning have all ended a little early as well. But you're right. I know Trauma Systems does typically last longer. Any other comments from the stakeholders before we?
I have a question. And it's just a thought. If we start going to the 1 hour and just the 2 day meetings, is that going to necessarily increase our outside work groups?
That's a good point. I know that before and I can only speak anecdotally about my involvement, but I know that the injury committee started having scheduling workday meetings before I was even on the injury prevention committee, because they couldn't get all the work done during the hour and a half that was allotted. I think by scheduling the workday meetings, now we are able to get it done. We probably even finish early. I know a lot of the other committees also have outside workday meetings. We've been doing this for at least 4 years. I anticipate we'll continue to do it as needed.
And I think that's why our meetings are typically at about an hour, because we do those 4 and 5 hour workday meetings throughout the year.
Susan?
One comment that I heard earlier was that if we reduce the lunch hour, the break time, that is the networking time that so many of us take advantage of, and that's a true benefit of being here. So something to consider.
Okay. So, Kara, do you still like option A?
I do.
Okay. What would be your second choice?
Actually, and this is just me, of course, but I like A, B, D, C, E.
And then F would be currently, so that would be your last choice is to keep it as status quo?
Yes.
Okay. Marianne?
I like D would be my first choice, and then, or no, wait a minute. E is my first choice, and D is my second choice.
Okay. Third choice?
Keep it the same.
Okay. Susan?
I would say that D is my first choice, E is my second, and keeping it the same would be my third.
Okay. Courtney?
I think I'd agree with Susan. D would be my first choice, E would be my second choice, and keeping it the same would be my third.
Okay. Debbie?
I think
We
I
do
would-
need to rank all of them. So if you do a 1 through 5,
Okay, Miriam, we're going to go back to you. So you said E, D, F.
E, D, F. I feel like I'm having an eye exam. E, D, F, C, A, and B.
Okay. Susan? You said D, E, and F.
Right. D, E, F, C, A, B.
Courtney?
D, E, F, C, A, B.
All right, Debbie. you get them all.
Does this mean I get contacts if I don't pass?
You have to sing it. That song.
E, D, F, B, C, A. Now, my first choice would be E, and then D, keeping it as it is, F, B, C, A.
Okay. Stuart?
B, E, A, C, D, F.
Okay. All right. Well, I will. I'll tally all of this and be prepared to present it to the GTAC Council on Friday. Okay. I think next thing is general public comment. Any comments? We still have 34 minutes. Okay. Any announcements from the group? From either committee members or Marianne, I saw that you have trauma conference in October.
There's flyers out there at the table.
Okay. Any announcements from the group, from the audience?
Shelley, I would like to say this is a little bit retrospective, but on May the 5th, Texas Harris hosted the Texas Trauma System Day, and it actually turned out to be pretty successful, even considering that it was on a Sunday. We had some very, very good speakers throughout the state of Texas. One of the highlights of the seminar or the conference was a talk by Dr. Robert McClellan, who is one of the last living physicians that took care of President Kennedy when he was assassinated. And it was very successful. So I would just like to thank Dr. Smith and also the help of the ACS to make that occur.
Thank you. Okay, this committee has a workday meeting scheduled for Friday, July the 26th here in Austin. Stuart, do you think it would be possible for you to get us a room at Dale on that day?
I'll
For that
certainly
day?
check.
Okay. And typically, we meet usually start around 9 or 10 o'clock. I'll get an agenda probably in the next few weeks. Our meetings usually end by noon. Anyone, these are public meetings, so anyone from the public is welcome to attend those meetings. At that meeting, we will be talking about probably position papers and things like that, so as well as other agenda items. Again, we also, if you have agenda items you would like for us to discuss, please email me, and we'll certainly consider those. The next GTAC meeting regular meeting is August, it's like the third week in August. Do you have that, Jane?
21st through 23rd.
Okay. Again, here in Austin. And so with that, we're going to end this meeting right at an hour. Meeting is adjourned.